Good morning, everybody. For those of you that are in person and for those that are online, we're going to go ahead and get started. We're about 7:31, so we'll get going and hopefully we'll see lots of others trickling in. So I have the pleasure of introducing, by the way, I'm Mark Gerber. For those that don't know me, I'm the Division Chief of Otolaryngology. I have the distinct pleasure of introducing Patrick Scheffler, who's one of the members of our division. Patrick trained starting with undergrad in medical school at the University of McGill University, and then did his residency at the University of Toronto and his fellowship at the Lucille Packard Children's Hospital at Stanford. He has a wide variety of interests, and today he's going to be talking to us about what to do with obstructive sleep apnea following adenotonsillectomy, some of the interesting things that we have in store. Patrick has developed a complex sleep program here that he is leading and is one of the leaders of the Inspire program, which is implanting a hypoglossal nerve stimulator to help, and that will be part of what he's going to talk to us today. So I'm looking forward to hearing the talk. Thanks, Patrick.
Thank you for the introduction. Hi, everybody. This morning, I'm Pat, one of the pediatric otolaryngologists here. So we'll talk a little bit about obstructive sleep apnea beyond the tonsils and adenoids. Some disclosures: we're going to use some off-label use of medication and devices. I do some consulting work with Inspire Medical, so I guess that biases me somewhat. Almost everything that is discussed today is off-label because most sleep interventions are actually technically not approved in children. Even any base of tongue surgery is technically not approved or covered by insurance in children, fun fact. And we're not going to talk about any bone work today, like maxillomandibular advancement. And this is definitely not a comprehensive talk on sleep surgery because there's dozens of procedures. So what's OSA? It's basically sleep state upper airway obstruction, which then leads to adverse breathing patterns. Basically, you have to muster an increased respiratory effort in order to maintain adequate airflow in your sleep. And then the airway obstruction leads to hypopnea events or apneic events, which then impacts the quality of your sleep. Hypopnea is a 50% airflow reduction associated with desaturation or arousal, and it's over 2 breaths, whereas an apnea is a complete cessation of airflow for at least 2 breaths associated with the desaturation, which is a little bit different from adults. In adults, you talk about an apnea being 10 plus seconds, but the reason why we go for only 2 breaths in kids is because they have a faster rest rate and lower FRC, and 10 seconds would be a much, much bigger impact on a kid than on an adult. We quantify obstructive sleep apnea and diagnose obstructive sleep apnea typically via a sleep study. And the main thing that people usually look at is the AHI or apnea-hypopnea index, which is apneas plus hypopneas divided by hours slept. 0 to 1 in most institutions is considered normal, so you're allowed to stop breathing up to once an hour. Up to 5 times is mild, up to 10 times moderate, and more than 10 times severe. Mind you, these norms are, first of all, different for adults, but for adults, the norms are actually fairly fixed versus for kids, there's no set norms. This is what we use here, but it varies a little bit by institution. There's also such a thing as obstructive hypoventilation, which is technically not obstructive sleep apnea because you're not having discrete events, but you basically have upper airway obstruction that leads to persistent hypercapnia and desaturation, but you don't have those discrete events we just talked about. That's also captured in a sleep study, but it's not included in OSA scoring. Symptoms of obstructive sleep apnea in kids at night, usually snoring, tossing and turning, mouth breathing, arousals or waking up. Enuresis is a big one. Sleepwalking or talking, bruxism, and then also exacerbation of nightmares and night terrors. And then daytime symptoms vary a little bit by age. They're usually excessive napping, difficulty getting out of bed in the morning. Behavioral concerns is a big one, acting out, sort of the grumpy, whiny child. And then also academic performance and development, because it's hard to go to school and perform well when you're sleep deprived. And this is just a graph. I'm not going to go into too much detail in, but it just shows you that symptoms sort of change very radically depending on getting older. There are some potential long-term sequelae with regards to sleep apnea, so there's a reason why we care. Really long-term sequelae involve RV or LV hypertrophy, pulmonary hypertension, systemic hypertension, copulmonale, polycythemia, neurodevelopmental issues. But those really depend on the severity. So usually more severe obstructive sleep apnea with more persistent hypercarbia and more desaturations, as well as the duration of the disease and also other comorbidities. Short-term sequelae, sleep quality, bags under the eyes, behavioral problems, school performance, and significantly decreased parental quality of life. There's a lot of studies out there that show that kids with severe sleep apnea make their parents miserable. And I think anybody here who has kids can probably relate to that. The old way to treat pediatric sleep apnea was sort of this. You had a kid with pediatric OSA, you took out the tonsils and adenoids, and if that worked, you were happy. If that didn't work, you tried some CPAP. If the child tolerated that, you were happy again. If they didn't tolerate it, then, well, try again in a few years. Or if really bad, hole in neck. That approach has sort of changed a lot over the last decade or two through advances in sleep surgery, which were mostly lead on the adult side. As I said, none of those, or most of those sleep surgical procedures are technically not approved in children, even though in adults they're well established. And treatment of persistent obstructive sleep apnea after TNA is increasingly surgical now. And it's really aimed at the level of obstruction, figuring out where the obstruction is coming from and treating that effectively. But, we always think, or we get taught, sleep apnea, you take out the tonsils and the adenoids, you finished, everything's great. So shouldn't persistent sleep apnea be rare? But the truth is that it's not, and I'll talk in a second about why. So a TNA will cure OSA in the normal weight, healthy child with minimal comorbidities and big tonsils and adenoids around 80–90% of the time, which is great. But then again, if you think about your own practices here at PCH, how many of your kids are healthy, normal weight, all that stuff? And really not that many. And that comes not just from our complexity, but also because the patients themselves that we're seeing are changing. There's a significant increase in childhood obesity in the US over the last 20 years. And a 2021 study showed obesity between age 2 and 19 to be close to 22%. So that's a problem. In Canada, we usually like to judge the US for a lot of things, but you can appreciate on this graph that it's the same up north. In terms of just looking at pediatric OSA, so in your normal, healthy, normal weight child, the prevalence of OSA is about 1 to 3%. It's actually not that bad. But if you look at overweight children and think about it, obese, not overweight, obese, 20% now. In overweight children, the prevalence is 25 to 45%. And in obese children, the prevalence of OSA is now 60%. So you're going to have a lot of children with obstructive sleep apnea. And these overweight and obese children will gradually present a larger portion of our practices. And the issue with obese patients, they're more likely to have very severe OSA. They're also more likely to have more poorly controlled asthma, which also contributes. They have an increased risk of perioperative respiratory complications. So those are the kids that you have to worry more about after surgery. They generally warrant a sleep study, but they're also much more likely to have persistent OSA. And we did a meta-analysis that showed that adenotonsillectomy cured OSA in overweight and obese children only about 40% of the time. So 60% of these kids will still have sleep apnea after surgery. There's also some other considerations that are even in non-obese children pushing towards a higher rate of persistent OSA. And that is increased recognition of how common allergic rhinitis is. So basically allergy-mediated upper airway inflammation, particularly within the nose. And that can also be a pathway to persistent sleep disorder breathing. And then lastly, sleep hygiene. There's also a lot of kids that you end up seeing that where you're wondering whether they have persistent OSA, but they just have really poor sleep hygiene. So this is how much kids should actually sleep per night, according to common recommendations. So in preschoolers, they should be getting 10 to 13 hours of sleep, school age 9 to 11 hours of sleep per night. And you're supposed to have not much activity or much stimulating experiences before going to sleep. If you think about that now, kids start playing on the tablets and phones basically as soon as they pop out the womb, and they usually do so right until they fall asleep. So sleep hygiene is terrible. And then lastly, this is not even talking about complex kids, but if you think about Phoenix children, so if you think about our patient population, there are a lot of complex children, whether it be issues of motor tone, whether it be anatomic issues, there are a lot of things that predispose our kids to have persistent sleep apnea. And that is why from a surgical standpoint, we should care. So as I said, persistent obstructive sleep apnea after tonsillectomy, about 20% overall, 60% in overweight and obese children, but obviously depending on how you define it. Risk factors are all of these: obesity, poorly controlled reflux, allergies, craniofacial and skeletal abnormalities, conditions affecting the tongue and tongue base, and obviously laryngotracheal abnormalities. In mild to moderate sleep apnea, management depends a little bit on severity and symptoms. There's some debate in the field whether we should even bother with mild sleep apnea or whether benign snoring can just be benign. You got to look at moderate. In moderate kids, especially, you got to look at some modifiable risk factors. Weight loss is a big one everybody talks about, but there's a lot of studies out there looking at behavioral weight loss programs in children, and they all kind of show that it doesn't work. So that's great. And then allergy testing, reflux management. Montelukast and Flonase on the medical side can be a really, really good option that is commonly used. Montelukast is a leukotriene receptor antagonist, which works really, really well. But the important side effect that all our parents have to know about is aggression and behavioral changes. And that side effect is very, very real. And it stops eventually after stopping that medication. But I have a lot of kids in my practice where the parents have experienced that side effect and have said no more. We often prescribe Montelukast and Flonase. These are just some graphs from a meta-analysis that are for some reason not showing up particularly well. But what they show is that the Flonase or the nasal steroids actually don't work. We're still prescribing them often for obstructive sleep apnea, but they don't do anything. But the Montelukast actually does a good job of dropping the AHI, so the events per hour, by about 4, and also preventing desaturations. Other things for moderate to severe obstructive sleep apnea that we're trying are dental appliances. They're not particularly well studied in kids. And the challenge is that you have that continuous mandibular and maxillary growth. So the craniofacial skeleton is continuously growing, which means you have to constantly adjust the dental appliance. And some of them are adjustable or remoldable. Some of them are not. And if you got to get them custom fitted repeatedly, that can be really, really annoying, first of all, for the family, especially if they're coming from far, but can also be an expense. And as I said, some of them can be refitted intermittently. I work with a dentist with an interest of sleep apnea in the community. One of the things we're going to try now actually is to fit. She has a patient that we want to fit in the operating room, where we put the patient to sleep, and we'll see how they're doing in terms of obstruction as we advance the dental appliance. Positive pressure therapy, or CPAP. That's been around for quite a while. It's very, very effective, but it's just poorly tolerated. And depending on what study you look at, so CPAP adherence is defined as 4 hours per night. So basically 4 hours per night of good sleep with a CPAP that actually works well. Adherence is very poor, though. It's about 10 to 50%, depending on what study you look at. And if you think about all the young kids, and especially the small kids in your practices, how many of them do you think are going to keep a CPAP or a BiPAP mask on all night? Not too many of them. So we end up being pushed to do what's called a DICE-with intervention, or drug-induced sleep endoscopy, which allows us to identify and address the source of obstruction. And basically what you do is the child goes to sleep into sort of a superficial plane of anesthesia with spontaneous respiration. And you're trying to induce obstruction. You're trying to get them to snore and obstruct. And usually we do that with propofol or dexmedetomidine. You don't want to use gas because that accentuates airway obstruction. And then you want to really identify that source of obstruction, and we'll go through them in a little bit of detail in a moment. The most common one is the tongue base in kids. And we'll talk about that in detail. Second most common is the velum, and after that, the supraglottis. The issue with this technique is that most kids stop breathing in their REM sleep, which is sort of the deepest sleep. But there's no medication that we have at this point that can recreate REM. So that always messes with us a little bit and sort of limits what we can actually see on drug-induced sleep endoscopy. With people from Inspire, we've developed a very specific protocol that we send to our anesthesiologists, and this just kind of goes through all the details of it. And these are sort of, everybody uses a different classification system, and that's fine. But these are really the sort of the different issues that we're looking at. We're looking at the velum and the posterior nasopharynx. We're looking at the oropharynx, the tongue base, and the larynx to see what they're doing. This is sort of a DICE step-by-step or image by image. So looking, the first step is to look at the nasal airway on both sides, where you look at, is the airway patent? Is it narrowed by the turbinates, or is it narrowed by septal deviation or anything like that? You sneak your way back and you look at the adenoid pad. why does that matter after adenotonsillectomy? Well, the adenoids can grow back, and it's actually not that uncommon. Then you sneak back and you take a look at the palate or the velum. And basically, ideally, what you want to see is on the top left, where everything's just nice and open as the child is breathing in. But you can also see collapse. And in the middle, you see sort of a partial collapse at the level of the velum, where you still have sort of ports on each side that you can breathe through. And then you see almost a complete collapse on the right. In kids who still have their tonsils, you look at whether they're kind of coming in or squeezing in the way. You can sort of see the tonsils coming in laterally there, and you can sort of appreciate how they can be obstructive in obstructive sleep apnea. You look at the tongue base, and basically what you want to see is whether the tongue base is falling back and basically pushing the epiglottis against the posterior pharyngeal wall and thus obstructing your airway. And I think you can see that sort of very impressively on the picture on the top right. Lingual tonsil, so many of you may not know, you have different amounts of tonsil tissue at the back of your tongue as well, called the lingual tonsil, and especially in kids with trisomy 21, that can get pretty impressively enlarged. And then you take a look at the larynx to sort of, or the different parts of the larynx, to see if they're collapsing or flopping in the way. Ways to address the nasal airway, very basic surgery, so I'm not going to talk into too much detail. Septoplasty, which, you know, people are sort of iffy about what age to start it at, and there's sort of different takes by everybody in kids because people are worried about mid-face growth. Turbinate reductions, which is an easy and quick surgery. And palate expansion and the dome procedure have become more popular in recent years in pediatric obstructive sleep apnea, with the idea that you want to address both the tongue position, so the way that the tongue rests against the palate or the roof of the mouth, but also in terms of widening the nasal airway. And palate expansion in young kids can be done fairly minimally invasively, in that you just place the palate expanders and you increase them gradually. But it can also be sort of done more invasively using a dome procedure, which is what they've been using for a little, or been doing even in younger kids at Stanford for a little while, where I trained. And basically the idea is you have a patient with a high arch, narrow palate, and you're wanting to improve nasal breathing, give room for the tongue to fit in the concavity of the palate. And you can also do that in conjunction with other procedures. The idea is that you're placing maxillary expanders, and that's what they look like, along the midline sutures of the maxilla. And then you're doing surgical osteotomies to split the midline suture and some of the forts. And then you have the ability with the expanders to turn them either every day or once a week, depending on what your schedule is like, to basically expand the palate and then the maxillary bone, and then let things heal. And in younger kids, you can expand a bit more aggressively and sort of turn a little bit every day. And the older you get, the less bone growth you have to go a lot slower. And then in older kids, expansion can take over a year. And then eventually, once you're happy, an orthodontist will close the gap between the two incisors, which you kind of see on the top right picture. That's a little bit much of a gap. That's not particularly aesthetically pleasing. And you can take off the expanders. I don't know how, it looks like the picture is showing up better there than for me. And you can sort of appreciate how you're trying to go from that arch-shaped palate to more of a dome. And that has been shown by Audrey Yoon and Stanley Liu at Stanford to actually work fairly well, not just in adults, but also in kids. They've measured the cross-sectional area of the internal nasal valve, which is the most significant part of nasal resistance or nasal obstruction. And they found that that is significantly improved, as well as subjective nasal breathing and sleep quality of life scores. There's the other interesting paper that they published, where I'm not quite sure how much I buy it, is they found that rapid palatal expansion in young kids actually seems to have an impact on the size of the adenoids and tonsils in children in a favorable way. I'm not quite sure how much I buy that or how that's supposed to work. But what the literature does show, predominantly in adults, is a significant decrease in AHI and significant improvement in obstructive sleep apnea. The other part we talked about is the collapse at the velum, and you can sort of appreciate three different patterns of collapse here. All the way on the left, you see what's called AP collapse, or anterior to posterior collapse. So we're just kind of describing how we're collapsing. In the middle, you appreciate lateral collapse, so the lateral walls come together. And then you have circumferential or concentric collapse all the way on the right. And these are different patterns to note. How you address velar collapse, there is a plethora of different surgeries, and every sleep surgeon out there has modified the technique in their own way, and they all say it's the only way and the best way to do it. But there's actually a really great pediatric study from Koltai et al. From a couple of years ago, where they've done in several hundred kids, they have done all kinds of different techniques, and the outcomes absolutely do not vary. So how you do it doesn't matter, just matters what you do. And really what matters is you're taking the laryngeus muscles, and you're basically pulling it into an outward and superior vector. So you're pulling the posterior pharynx, that particular muscle, you're pulling it outward to try and increase your space back there, and that also helps with collapse. And then at the end, it looks something like this, depending on what you do with the uvula, which there's also a lot of papers and a lot of different opinions on, and none of them seem to really matter. The tongue base is really the most common location of obstruction. This is lingual tonsillar hypertrophy, which we talked about. So it's when you have that tonsil tissue there, which you can relatively easily zap off. You can use a co-blader, which is what I do and a lot of my friends do. You can use the microdivider, or if you have an interest in taking a 45-minute surgery and turning it into a 3-hour surgery, you can use the robot. If you're lucky enough to have one. It's expensive, but it's fancy, and families seem to love it from what I hear from my friends. Tongue-based suspension is a great option for tongue-based collapse. So if the tongue is falling backwards, and that's the issue of the obstruction, you can try to suspend the tongue base. And the way that you do that is you take some screws and you drill them into the mandible, and then you take a suture that you put through the base of tongue under fluoroscopic guidance, and you sort of pull that base of tongue forward and tie it to that suture. It sounds a little morbid, but it's actually super well tolerated, believe it or not. And it seems to work fairly well. And I brought a video of my colleague Tahar Velika at Northwestern, who's sort of the main guy who's been pushing that technique in the pediatric population. Does a really nice job with it. So dissection through the neck down. This is the weird little apparatus that passes the suture, because otherwise getting a suture through the tongue base can be a little hard. It's sort of this weird thing that passes the suture around, then clicks in, and you can pull it through and pull it forward. And you're feeling at the back of the tongue. Here you can see with fluoroscopy, you're pushing the passive forward towards the tongue base, looking where you're going. And once you're happy with where you are, you're deploying the suture, and you can pull the tongue base forward. And then tie it to the screws that you have in the jaw. And that actually does a really, really nice job dealing with tongue base obstruction. The issues with it is that you have hardware sitting in bone, which from an infection risk standpoint, sometimes makes people a little bit queasy. The other thing is that they haven't gotten MRI safety approval from FDA and other pieces, so it's not a great option. Kids who need where you think they'll need a lot of MRIs above the shoulder. And the other thing is that it hurts, but it seems to be effective. Whoop, there's a typo in there. Effectiveness is about 30% on its own, 30.5%, not 305%. I wish it were 305%. And it's about 70% when you also combine it with a palate procedure. And the reason for that is that in complex kids, you often have more than one level of collapse. You don't just have the tongue base falling back and nothing else, but often you also have collapse at the velum. In terms of my results, I've done 7 of those so far, so not a ton. And 6 out of 7 did really, really well with an apnea-hypopnea index afterwards below 5. But patient selection is key. One kid that I did this on in a hope that we would be able to decannulate him because he had a horrible AHI, also had other craniofacial anomalies that I think contributed to us just not getting there. And I know Nate knows that patient very well. Hypoglossal nerve stimulation, which is my personal favorite when it comes to tongue-based collapse, has sort of become one of the mainstays of treatment of CPAP intolerant OSA in adults. There was no pediatric indication until approximately 1 month ago, where the FDA approved it for children with Down syndrome, and basically addresses tongue-based collapse by stimulating tongue stiffening and protrusion on inspiration. So the idea is that you find your hypoglossal nerve, you dissect it out, you find what's called the functional break point, where you have the protrusor branches and the retrusor branches sort of coming apart. You dissect that out. You only pick out the branches that you want to include, which you identify with stimulation, and you put a little stimulating cup around it, and then test it. The idea is that, as I said, when the patient breathes in, you want the tongue to be pushed out and stiffened, and when it breathes out, it comes back in. And the way that it notices whether you're breathing in or not is that you have this generator that sits under the skin on the chest, and you have a sensing lead that you place between the intercostal muscles that then senses inspiration and expiration. And then at the end of the procedure, you get to test it, which is always fun for the whole family. So just look at the tongue over at the mouth. There it comes out. And back in. And back out. And basically that's what it does during the patient's sleep as well, just a little less. And it works really, really well for tongue-based obstruction. The current indication is for kids with trisomy 21, age 13 to 18, with an AHI of 10 to 50 events per hour who don't tolerate CPAP. At this institution, and basically that's based on a study of 42 patients from multiple institutions. They back then looked at kids age 10 to 18, which is sort of more commonly what's being implanted across the country. And it showed a mean decrease in AHI of 12.9 events per hour. 65% had an AHI decrease by more than 50%. And 3 out of 4 kids had an AHI below 10, so from severe to moderate OSA at 12 months. So lasting improvement and improved scores in terms of their symptom scores. 5% of patients required reoperation for different reasons. And that sort of mirrors out our data. So those are the kids that we have that have now more than 6 months follow-up. We have a bunch more that have less than that. And we've also found sort of similar numbers that we've had basically mean reduction in AHI by about 67%, which is great. All of our patients actually had a sustained reduction above 50% in AHI, which is fantastic. And 50% of the patients that we have 12 plus months follow-up are completely free from OSA at this stage. One patient ceased device usage, and that kid I'm actually explanting in about 2 hours from now. The reason why the child ceased usage is not because the child didn't tolerate it, and we actually got a good reduction in AHI, but the mom just continues not to be comfortable with having an implant in the patient or an electronic device in the patient. She thought she'd be comfortable with it initially, which is why we implanted the child, but now she's just freaked out by the idea that there's something in her child that turns on and off at night. So we're explanting the kid today. And that is the patient that requires reoperation. In terms of our non-trisomy 21 patients, we're also starting to broaden our indications a little bit. I have one mucopolysaccharidosis child that I implanted about a month ago that should be activated soon. I have a child with Wolff-Hirschhorn, and we've started also implanting patients with cerebral palsy, which hasn't been done before. 2 of them, one of them is still pending their implant, one is pending their sleep study, and one has had their implant now for a little while. And that patient with cerebral palsy, we dropped how many events they have per hour from 114 events per hour down to 12. Which is a pretty significant improvement. And we have one healthy non-syndromic teenager that we're implanting soon. So in summary, persistent OSA is an increasing problem in pediatric patients. CPAP adherence is really, really poor, which is creating higher reliance on surgical interventions. And there is just an increasing role for surgical intervention for OSA. And the one parting thought that I want to leave you with is that maybe in complex patients, instead of just jumping straight to tonsils and adenoids as our primary approach, maybe we should start going with drug-induced sleep endoscopy guided intervention to begin with. This is a 12-year-old patient of mine who has trisomy 21. She did not have her adenoids and tonsils out. And as you can see on sleep endoscopy on the left side, that big sort of ugly looking thing that seems to be obstructing everything there is her tongue. And on the right side, you have a picture with jaw thrust. On neither of these pictures do you see her tonsils. Her tonsils are barely visible. She has tiny tonsils. She clearly also has no adenoid obstruction. Having said that, according to the old way that we've been treating obstructive sleep apnea, and the only way that actually insurance will let us treat it sleep apnea is we have to take her tonsils and adenoids out, put her through a procedure that required 1 night observation that has a 1-week recovery from hell with a depending on who you read, 2 to 5% risk of postoperative bleeding. just to be able to say we've done it. It hasn't changed her AHI at all, and now she needs another intervention to begin with. So my parting thought is maybe in complex kids, we should just completely stop treating sleep apnea the way we've treated it for the last 30, 40 years and just completely change our paradigm. That's all I got for you today. Thanks so much for your attention. Yeah.
It looks like it off.
Yeah, you do feel it. The way it gets turned on is you turn it on when you go to sleep, and there's a delay. So if you know based on experience that you're falling asleep, let's say 30 minutes after going to bed, you'll set the delay for 40 minutes, 45 minutes, and that way it kicks in after you've already fallen asleep. And after you activate the implant, you start initially stimulation at subacute levels, and sort of every week you increase it a little bit to make sure that you maximize your chances for tolerance and minimize the chance for waking up.
Still have a good sized audience on Zoom, and they need to have us use the microphones to hear the questions. Thanks so much for the talk. It was great. I just have a question. I'm not in primary care, but like my son snores. So should he come see an ENT, or like what's the next step? Or do they go to sleep physician?
Yeah. If you go to a sleep physician, typically they may order a sleep study or not, or they may just tell you to see an otolaryngologist. So not of otherwise healthy kids who snore and toss and turn, sometimes the diagnosis of obstructive sleep apnea is just made based on symptoms. So if you have sort of big tonsils, big adenoids, and you have all the symptoms of sleep apnea, we may advise to take out the tonsils to begin with. If the history is more unclear or the exam is more unclear, we may order a sleep study. But often, if you see a sleep physician, they'll send you to ENT either way.
And I just had a second question. We see a lot of kids with pectus excavatum, and a lot of those kids have a normally shaped chest. They develop the excavatum in adolescence, but I'd say probably about 20% of the kids have it since they're babies. And I've read somewhere that perhaps upper airway obstruction can contribute to that pectus excavatum. Do you think that there's any, due to the increased negative pressure in the thorax, do you think there's any merit to that argument?
I have no idea. It sounds plausible to me, but my honest answer is I have no idea.
I would tend to agree. I think there's potential, but humans are just can be honest.
We see it in parental relations.
Yeah.
You start with significant obstruction very early, chest problem, getting compliant. I don't know that I've seen it in like a 6-year-old that obstructs developing that.
But then on the other side of that, we see lots of kids with severe obstruction that they get obstruction, with laryngomalacia or other airway obstruction, and or sternal retraction, but if they don't do it.
I guess the only way you can study it is you'd have to choose not to treat half of them and follow them for 10, 12 years, which.
You think we're going to get to a point? You mentioned these children who have small tonsils and adenoids, and we're not quite sure that those tonsils and adenoids are making a play for obstruction. Do you think we'll get to a point where some of the secondary procedures are able to be approved without going to tonsillectomy first? Right now, that's not the case.
Right. I think we will eventually. One actually already is. So palate expansion often gets approved even without TNA, even in patients with a positive sleep study. So I think we're already halfway there, and there's an argument to be made for that.
I'm curious about your interaction with dental specialists.
I'm curious about your interaction with dental specialists regarding sleep apnea. There's certainly some squirrely stuff that we see out there in the dental world regarding airway issues, but I think there's a great place for collaboration. I'm wondering how you found a partner and what you guys have done.
Yeah. What we've done, we haven't done much. We're doing stuff. So as I said, we're doing the thing with the device or mandibular device, where we're going to see if we can fit one with the dice and see whether that really helps in terms of alleviating obstruction. She does a lot of she does a lot of palate expansions with pre and post-op sleep studies and her practice. So we're going to study what her outcomes are like and try to report them. There's a lot of squirrely stuff in dentistry out there, like a lot of brouhaha about if you cut a tongue tight too early in life, it causes sleep apnea. And then if you don't cut it, it causes sleep apnea. There's a lot of weird stuff out there, but there's also a lot of zealots and crazy people in all specialties, including ENT, including anything. So I think it's just sort of actually studying the things, and maybe some of those things that sound crazy don't end up being crazy at all.
You got quiet. Are we able to see if there's any questions from the audience online?
It's one comment thing that's very interesting.
Very good.
Thanks so much.
Thank you, everybody.